Ladies and gentlemen, it is often thought that the history hinges upon great battles, both in war and competing ideas. The stars could be a few powerful individuals, presidents, monarchs, dictators. But some influential actors are microscopic and can be nasty and ruthless. In his book, 12 Diseases That Change Our World, Irving Sherman, a professor of biology at the University in California, describes how parasites, bacteria, and viruses swept through cities, devastated populations, transformed politics, public health, and economies. Some of these include smallpox, bubonic plague, syphilis, cholera, TB, influenza, AIDS, and most recently, Ebola and the ongoing pandemic of Zika virus diseases. Infectious diseases have shaped human history, and there is every evidence that these diseases will continue to be significant global events. We are living and working in an unprecedented era of emerging infectious diseases, and an era in which zoonotic pathogens are playing a dominant role. Right. I just want to move the slide, but doesn't want to move. I think we need an IT guy again here. So my presentation is on the origin, epidemiology, and control of Ebola epidemic in West Africa. But also I would like to give you some kind of introduction about the factors which are leading to the emergence of zoonotic pathogens. Page down. Okay, great, thank you. The interdependence of people and animals and the many different factors controlling these relationships are converging to create environment that is conducive to the emergence of epidemic-prone pathogens. The recent examples are SARS, West Nile, avian influenza, MERS, Ebola, Zika, and yellow fever. You might know that yellow fever just broke recently in our neighboring countries, and this is probably due to the lack of continuous vaccination or shortage of vaccine against yellow fever. So the emergence of these pathogens is a global wake-up to improve our ability in prevention, detection, diagnosis, surveillance, response, and research activities. Emerging infectious diseases are also a sobering reminder of the tremendous socioeconomic and trade damage that these group of pathogens can cause. In recent publication by the US Institute of Medicine entitled Microbial Threats to Health Emergence, Detection and Response, the authors suggest that a group of factors are swirling and converging to create a perfect microbial storm. And during my presentation, I will explain why Ebola outbreak in West Africa is an example of the perfect microbial storm. This metaphor helps describe the conditions and dynamics that have produced a new era of emerging diseases about 4 decades ago. Biological, socioeconomic, ecological, anthropogenic factors are creating a perfect conditions for a storm for emerging and re-emerging zoonoses. Also, changes in our weather, climate, ecosystems, economic developments, and land use continue to alter the dynamics between vectors, hosts in a novel way. Over the last several decades, there has been an average of almost 1 new emerging disease each year, and approximately 75% of these diseases have been zoonotic, of animal origin. With the acceleration and expansion of global trade, human movement and travel, and the escalating population of both people and animals, the microbes have an even greater opportunity to adapt change and be transported to new ecosystems, often with catastrophic results. I wonder if anybody here recalls an outbreak of a new arenavirus in Johannesburg, Morningside Hospital, private hospital, 2008. That is an example when a new pathogen has been imported to South Africa. As you might know, there's about 50 fatal patients which are treated weekly in private hospitals in South Africa, and obviously that poses a danger of the introduction of new pathogens to our country. These are some of the factors of emergence: ecological changes, disruption of ecosystems, uncontrolled human demographics, social, economic, and political disruptions, technology and industry, movement of animals, often uncontrolled or illegal, poverty, and social inequality. Many scientists accuse nature as being the worst and the most unpredictable bioterrorist. But if you look at the factors of emergence, who is actually creating those? Who is to blame, really? Nature is forgiving and gracious. These are some of factors which are leading to emerging of pathogens, zoonotic pathogens. For example, building of dams is expanding the breeding habitats of mosquitoes, and that is eventually leading to the outbreak of Rift Valley fever or hantavirus pulmonary syndrome. Human demographics like movement from rural areas to cities and uncontrolled urbanization is also leading to the outbreaks of dengue. Hunting of wildlife and consumption of bushmeat is likely leading to the outbreaks of Ebola, for example. International travel and commerce contributes to the dissemination of mosquito vectors and outbreaks of some respiratory diseases like SARS and MERS. And there's many more examples like that. Emerging zoonotic diseases have created a new kaleidoscopic lens through which we view our world. And now I would refer to your good imagination. These diseases will not only continue to emerge, but probably will do so at an even more increasing scale. To take this visual metaphor further, how do we project the kaleidoscopic image into the crystal ball to see what the future might hold? Unfortunately, predictions are not quite possible, and each new disease that emerges has come from an unsuspected source. However, what is certain that there will be many more infectious diseases, and both public and veterinary health communities need to be better prepared. These are some pictures showing the factors leading to the emergence of zoonotic pathogens, including the urbanization, population growth, but also poverty. The globalization of the food productions. If something will happen during this process, obviously many countries can be affected. If you buy a chicken in Kentucky, somewhere in Pretoria, in Johannesburg, you don't really know where is this chicken from. This is a picture which I took while being a part of the Ebola response in Sierra Leone. This is Freetown. This is the capital of Sierra Leone, and this is very close to the city. So obviously sanitation is a problem. These pigs foraging on the waste, there was some article in press that some of these pigs eaten new unattended newborn kids. Consumption of the bushmeat is a problem, but obviously what is the reason that people do eat and hunt the wildlife? Obviously the hunger and poverty. There's a duiker you can buy at the roadside in Gabon. This is a monkey. I took this picture while traveling to Gabon to set up a research camp to hunt for Ebola virus during the Ebola outbreak there. Bats can be purchased on the African markets in different culinary forms. Do you know that bushmeat is highly prized by humans in Central Equatorial Africa? People do hunt monkeys, chimpanzees, gorillas, bush pigs, duikers, chevrotins, pangolins, porcupines, civets. Just in Central Africa alone, between 1 to 3.4 million tons of bushmeat is consumed annually. 25 tons of turtles are exported from Indonesia every week. 28,000 primates are hunted annually in Peru. So obviously that these animals could be a source of a spillover of the new pathogens to human population. In order to strengthen the efficacy and early warning systems, monitoring trends and disease prediction, and timely outbreak intervention, it is essential that each nation improves its own capacity in disease recognition and laboratory competence. And when I look at this information displayed here, what is needed, that's exactly everything is there: leadership, solution, medicines, research, and so on and so forth. The problem is this goal possible? And who will pay for it? Did we shape our thinking, responses, understanding of microbes, evolutionary biology, and ecology? Is there political will to accelerate mobilization of resources and clear understanding that health is not an expense, but investment? Do we have in place well-resourced and fully functional emerging infectious surveillance and response systems? Some of these examples, like SARS, HIV/AIDS, avian influenza, MERS, and Ebola virus diseases, were not actually managed in time and were not managed properly. So this is a shame, and I'm afraid that on many occasions this situation will repeat. There's a number of challenges hampering progress, response and control of emerging zoonotic diseases in Africa, including insufficient and uncoordinated surveillance and research programs, limited regional capacity to develop, validate, and implement new and improved diagnostic assays. Most of the diagnostic assays for infectious diseases which we are using in Africa are developed and manufactured in the developing world. And we're paying millions of dollars to use them. The capacity to develop new diagnostic products on African continent is very, very limited. We don't have adequate biocontainment infrastructure for working with dangerous pathogens, which limits our research programs on highly consequous pathogens. Also, there's a lack of regional certification system and authorization for commissioning of high and maximum containment facilities. There's also lack of strategic African biobanks for long-term and secure storage of reference materials, strains, and preserving African pathogen biodiversity for future development of diagnostic assays, vaccines, and therapeutics. Many of our pathogens are transported to developed countries, and African scientists hardly have an access to work on those pathogens. There's also a lack of regional external quality insurance for most of the dangerous pathogens. We know that Africa continent suffers from one of the highest burdens of infectious diseases, yet we have the least capacity for their detection, identification, and monitoring. However, studies on the risk of spread of emerging infectious diseases point to Africa and Asia as likely to harbor the endemic settings for both conventional and emerging epidemic diseases, especially at the human-livestock wildlife interface. There's many lessons learned from recent epidemics in Africa and elsewhere which clearly indicate the need for coordinated research through interdisciplinary centers, response systems and infrastructure, integrated surveillance, and workforce development strategies, more and stronger partnership across national and international partners. We can't work anymore in silos. We need an integrated research approach to zoonotic pathogens, biology, ecology, and epidemiology. We need one health focus on infectious diseases, including different sectors, in order to improve the well-being and health both of public and animals. This report I provided to you also mention the new initiative in the world named Global Health Security Agenda, and maybe some of you are involved in some of these activities. This Global Health Security Agenda is an international program which aims to accelerate progress towards implementation of WHO international health regulations and World Organization of Animals Performance Veterinary Services to prevent avoidable epidemics, detect threats early, and respond rapidly and effectively to biological threats. And these are some of the action packages, and South Africa is currently leading the national laboratory system in this program. What is required? We need innovative, African-led approaches, not donor-driven projects, to make the necessary quantum leap in the development of scientific capacity for surveillance and control of infectious diseases to ensure health security at community level. We need better tools. We need better epidemiological, socio-anthropological, communication, cultural sensitive, cost-effective, and remotely accessible tools for detection, identification, and monitoring of infectious diseases. We have to use digital technology-based syndromic surveillance tools. We also need lateral flow point-of-care assays for single and multi-pathogen detection for differential diagnosis. These tools should be cost-effective and sustainable, implemented and applied at community levels and with community engagement. Now, to set up better the scene for this presentation, I would like you to present a very, very short video. This is not a perfect video because I took this on my cell phone while being in Sierra Leone. But this is a very, very appealing video and explains some of the problems encountered during the Ebola outbreak. I hope it works. The Ebola virus disease is caused not only by one virus. It's actually caused by 3 different strains of Ebola. Ebola Zaire, which is the most pathogenic, the Ebola Sudan, and also the Ebola Bundibujo. I don't have too much time to go through the natural history of these diseases, but the virus belongs to the Filoviridae families, and this family is represented by 3 genuses: Marburg virus, Quer virus, and Ebola virus. Maybe what is worth to mention that Marburg virus was meant to be less pathogenic than Ebola, but the outbreak in Angola in 2004-2005 actually proved us wrong again. This virus can also cause case mortality rate up to 90%. There were close to 300 people who died during the Angolan Marburg outbreak. The Marburg virus occurs in more drier savanna zones and in caves, and maybe some reports people entering caves often became infected with this virus, and some of them died. Ebola viruses occur in the rainforest ecosystems and on the forest-savanna interface. The virus is a non-segmented negative sense RNA virus. The names comes from Latin filum, thread-like, and the appearance of this virus is actually quite scary. Looks like a worm, isn't it? The first Ebola outbreak was recognized in Democratic Republic of Congo, former Zaire, in 1976, followed by a small outbreak, including just 1 patient the next year, and then for 18 years, the virus disappeared. But from 1994, there is an increase of Ebola outbreaks. But before the West African Ebola outbreak, until 2040, the total outbreaks caused by Ebola Zaire was about 15 over 38 years period of time. Number of cases, close to 1,500, 11,000 deaths, and the case fatality rate 74%. The next species of Ebola, Ebola Sudan, was also recognized the same year as Ebola Zaire in 1976, and one of the major outbreaks which was noted so far occurred in Uganda in 2001, where 425 people were infected, of which 224 died. The overall case fatality rate by Ebola Sudan is 50%, and recently another species was discovered in Uganda, so-called Bundibujo Ebola virus. So far, this virus caused 2 outbreaks, 1 in Uganda, 1 in DRC, and the overall case fatality for this virus is 27%. Signs and symptoms, early symptoms are not very specific. They include fever, headaches, myalgia, arthralgia, extreme weakness, vomiting, conjunctival injection, sore throat, hiccups and rash. Later, bleeding, chest pain, hearing loss, and blindness. And terminal patients, there's a shock, anuria, hyperventilation. In convalescent patients, there's prolonged myalgia and also ocular disease, hearing loss, orchitis, often blindness, frequent and severe lasting weakness, and prolonged asthenia. This is kind of a statement made by Dr. Margaret Nyayonga, who was a psychological support officer of the WHO in Kenema, in Sierra Leone. That's some complaints by the patients who survived. Some complain of clouded vision, but for others the visual loss is progressive and some became blind. Apart from visual problems, which affects about 50% Ebola survivors in Kenema, people complain of joint pain, muscle and chest pain, headaches, and extreme fatigue. So there is a severe post-Ebola syndrome, and obviously these people actually are still suffering. But you know what is even more worrying, that because of traditional mindsets and ill-founded rumors, those people who survived are actually very often seen as people who were casted by witches, because how they could survive, such as diseases. A woman's husband had been a health worker during the crisis and unknowingly contracted the virus. She survived the diseases that killed her husband, but was left homeless, ostracized by the community who actually threatened her to kill her if she would return home. Another example, another survivor, healthcare worker, became suicidal after a patient refused her touch. And some survivors haven't been touched for more than 1 year. One is saying, I survived but feel like a different human being, and I am different from other people. Even my family rejects me now. My son died on my lap in the taxi. I was forced to hold it tight so people don't know it's Ebola. And it's not just there. I remember when I was coming back from Sierra Leone from my missions, people were interested in what I've done there, but they didn't want to touch me. They didn't want to give me a handshake. They didn't want to hug me. And maybe Prof. Elżbieta also in the audience, she can recall this kind of a moment which we were meeting. And there was a circle of people around me, and they wanted to hear what I've done there. But they were very, very suspicious if actually I am still okay. And obviously there were many problems because I led a number of teams I will show you later on if the time allows. And obviously the problem was that members of my teams, they were never exposed to such as operations. So my task was not only to train them, but also to make sure that they were coming safely home. If you're coming home from such as outbreak situations, you don't know if you can kiss your wife, you don't know if you can kiss your children, you don't know if you can sex, because that Ebola virus can actually infect the reproductive tract, and it has been shown that the virus can be in semen for a prolonged time. So there's many, many issues related to this. Anyway, I will skip that, and pathology, immunohistochemistry, and electron microscopy identifies very intensive replication of the virus in different cells, macrophages, monocytes, endothelial cells, and dendritic cells, fibroblasts. Obviously, infection of some of the cells is actually impending on the innate response and other humoral responses. The virus starts to replicate uncontrolled in different tissues, leading to disseminated intravascular coagulation and thrombosis-related multi-organ failure, eventually resulting in death. The problem is with the treatment. The treatment is mainly symptomatic, and African hospital settings have special consideration because the family attendance is required. Some of the pictures quite sensitive. But bleeding is not actually a prominent clinical manifestation. The bleeding, such as I show you, occur in about 16% of the patients. So the first symptoms are very unspecific, and this is a problem because very often the Ebola or early stages of Ebola are misdiagnosed with the more common occurring infections in Africa, like, for example, malaria, Shiga loris, or typhoid fever. So this is just symptoms and signs recorded in 103 patients hospitalized during the 1995 outbreak of Ebola in DRC, and you can see that the bleeding is not a prominent sign. The same was the case in the current outbreak in West Africa. The Ebola outbreaks occur in very, very remote and usually impoverished areas or regions or locations in Africa. These are patients waiting to be admitted to the doctor. And this is a hospital in Luebo. Mothers waiting for the doctor. And this is the TB histopathology lab. This is the room where the clinical history of patients are stored. And this is the pediatric ward stretcher. A pressure cooker to sterilize the instruments, surgical instruments, and storage of the gowns. And that's the family attendance required because, the family, they have to feed their loved ones. We are much better. Obviously, I guess that compared to some other places, we are still living in a paradise. Working with Ebola and other biosafety level 4 pathogens requires highly specialized and very, very expensive biocontainment facility. And this is just a picture of biosafety level 4, the maximum security level infrastructure in Sandringham, Johannesburg. The kind of a general belief is that Ebola is maintained in nature by bats and is spread within the bat populations by contact bite or sexual transmission, or maybe by ectoparasites bites. And then through contact, it's spread to monkeys or other primates and eventually to human. The other more complicated hypothesis about the transmission of Ebola or filoviruses postulates that maybe these viruses are plant viruses, which then, when the plant bugs are eating them, they are infected, and if these arthropods are predated by insectivorous vertebrate, eventually they infect those vertebrates and then are transmitted to bat and humans and non-human primates. None of these hypotheses is actually proven, and as you might know, the Ebola virus hasn't been isolated from any wildlife species, so it still remains the most hunted treasure in the modern virology. This is just a picture showing some work we're doing in biosafety level 4 in Johannesburg, experimental work with bats. And also we do a number of experimental work and also field studies. We recently discovered that some of the caves in South Africa, which are heavily habitated by the Rosetus aegyptiacus, an Egyptian fruit bat, they are infected with Marburg virus. I don't know if that is going to work, but just to show you maybe. Okay, so this is a video showing some work in biosafety level 4, some experimental work which we doing in this facility. You need specially trained people. You can't work more than 4 hours in such a facility because the air which is supplied to the suit is very, very dry. So you dehydrate very, very quick. And also people who are claustrophobic, unfortunately, they are not capable to work in such facilities because beside the fact that you have to work in this full plastic enclosure, you also have to go through a number of chemical showers, and these are quite claustrophobic cubicles, and you are actually going through the heavy shower. It takes about 100 liters of water, including very, very foamy disinfectant. So once the disinfectant is poured on you, you can't see hardly anything. So if you're claustrophobic, you can't really work there. The other problem is that you need also a big bladder because going in takes plenty of time, going out takes your time. So if you have a problem, you have to go and pee too often, then you will spend more time in toilet than in a P4. So the one question we ask when we interview people, the size of the bladder, and are you claustrophobic? If you don't fulfill these 2 requirements, unfortunately, you could be the most skilled scientist. You won't actually qualify for work in our team. Okay, so from time to time we go to the field and we hunt bats. Some of these bats have a big, big teeth, so you have to be also well trained not to be bitten by them. And we dissect these bats in the field. This is the trip to Luebo around the hospital I showed you. We went there shortly after the outbreak because we thought that's a perfect time to hunt for Ebola. And this is Lula River. And we were looking for some suitable habitats where we can actually collect bats. And we spoke to local people. We also looked at the local markets for some evidence if indeed bats and the wildlife is prevalent of these markets. Obviously it was. And pigs are very, very liked by bats. And if you see the fig trees, then you know that the bats are around. So we set up the lab there. This is kind of the field lab, and we actually collected mostly this bat species. This is Hypsignathus monstruosus, hammer-headed bat. And the one reason why we were especially interested in this bat is that this is very, very much hunted bat species by local people. The male of this bat species could be up to 400 grams. So it's like a flying chicken. If you catch a bat like that, you've got a very, very good meal. So we collected about more than 40 individuals. They were dissected in the field. Specimens were brought to the BSL-4 facility in South Africa. We tested each single tissue, lungs, kidney, intestines, and stomachs, and the reproductive tract, and the results were zero. We couldn't actually detect the Ebola virus there. So to somehow mitigate the problem with kind of investigating and trying to understand what's really going in the bat population in nature, we established a bat colony. We do have a bat colony of Egyptian fruit bats close to our P4. And from time to time, we run some experiments of those. My question here, if you look at this video, is the contact close? Is that contact close between the bats? I think this is almost nose-to-nose contact. It's very direct, close contact, isn't it? The point I'm trying to make here, that we had 8 cages like that, and each cage had infected and non-infected bats. Infected bats were kept with non-infected bats for 42 days, and we couldn't evidence transmission of the marble between these bats. So there's something strange going on, and we still don't understand, what is the entry and exit points of these viruses. Now quickly to this, you probably recall this statement during the Ebola outbreak. Many governments were ensuring their own nations that the situation, Ebola situation, is completely under the control. And that some statements, NICD and our government also were releasing some of these statements that we know how to fight these diseases. It's not a mystery. We know the science. We know how to prevent it from spreading, and we know how to care for those who contracted it. So why Ebola containment was not working in West Africa? Do we really know how to fight these diseases? Is it not a mystery? Do we know the science? Do we know how to prevent it from spreading? Do we know how to care for those who contracted it? So until 2014, the Ebola outbreaks were confined to the equatorial Africa, but also in East Africa. And then suddenly there was an outbreak in West Africa, and that was the first outbreak in this part of Africa. So none of these nations were actually, none of this nation was prepared. There was no emergency or contingency plan, and the knowledge about the transmission of this virus, and the knowledge about the treatment, but also the knowledge how to actually control this disease was almost not existing. So a little bit of the chronology of this outbreak, retrospective investigation which were carried by WHO and also the Guinea health officials identified a 2-year-old boy as an index case of this epidemic. This boy became sick on 26th of December and died 2 days later. He showed he had fever, but also black stools and vomiting. And soon after, his sister, his mother, and the grandmother died with the same symptoms, and then the extended family started to die, and then the midwives and doctors who were caring of these sick people, they also started to die. So that's how it started. But unfortunately, the index case was only recognized retrospectively, and it took months for this outbreak to be recognized. During this time, the virus is silently spreading from Guinea to neighboring countries, to Liberia and Sierra Leone. Now, if you just remember some of these factors leading to emergence of infectious diseases, I mentioned to you disruption of ecosystems, deforestation. What apparently happened, this boy was seen playing with bats in his backyard a few days before he became sick. And he was playing with a specific bat species which were habitating a hollow tree on his background. And that was insectivore bat species, Bobs condylurus. And this bat species was shown in 1996 to be susceptible to Ebola Zaire infection. So this species can replicate the virus but doesn't show any symptoms. Why it happened? The outbreak, the index case, occurred in Meliando, which is a small, remote, sparsely populated village in a forest area of Guinea. And around Meliando, for years, there was plenty going on. Mining and timber operations, which destroyed a surrounding forest. About 80% of the surrounding forest has been destroyed. And that probably brought the wild animals and also the bats, which are thought a reservoir species of this bird, closer to the human settlements. So that's some of the factors which can contribute to emergence of such as pathogens. Deforestation, for example, and obviously ecosystem disruption. So only on the 25th March, the outbreak is recognized officially by the health authorities in Guinea, but at that time, the virus is already spreading. In late May, it's already in Conakry. Then in late July, it's already in Freetown. And in mid-June, it's already in Monrovia. So the fear that eventually the virus will reach and embed in highly populated post-conflict and impoverished cities in West Africa has been materialized. So eventually, on 8 August 2014, WHO declares the Ebola outbreak in West Africa as a public health emergency of international concern. And on 19 September 2014, the UN Security Council declares the Ebola outbreak in West Africa as a threat to peace and security. So some people do ask, yeah, during that time, more people were dying from malaria. During that time, more people were dying from influenza and other more common diseases. Yes, that's true. But did malaria, did HIV/AIDS, did tuberculosis ever stop the world? Never. Ebola did. SARS did. So we referring here to some public health emergency which do have some kind of international relevance. So this outbreak is completely out of the control, and the cases are rising faster than the ability to contain them, and Ebola needs to be stopped at the source to prevent the spreading. Some countries, many countries, started to stop their borders, to close their borders, and actually refused to help. It took quite a while before the world actually reacted to this outbreak. This was just not a health threat, but was also a humanitarian crisis and socio-economic crisis. I think I have to go a little bit faster through this slide. Obviously, family members are dying, and there's many orphans on the streets. And this is just a picture, just to illustrate you. Imagine yourself. Imagine you are this 9-year-old girl, which is taken by foreign healthcare workers, which are covered with layers of plastics, and you hardly can see their faces, and they don't speak the local language. And you are taken to the isolation ward, and that's the first time where you see your father, mother, or your loved ones. So obviously there were many problems during this outbreak. That's one of the reasons I show you in this video why people were not happy. So that's the numbers. Obviously this is the unprecedented and the largest and the most spread outbreak in the history of these diseases. And unfortunately, many healthcare workers died during this outbreak. And there was really a problem. For example, Sierra Leone, before the outbreak, had about 150 doctors. For 5 million population, they need 4,000. They can only produce about 20, maybe 30 doctors in their medical school. So it would take them about 20, 40 years actually to get to this number. Yes, so obviously there's many problems. So these outbreaks are also leading to the significant reduction of the GPD and that's kind of a mechanism leading to that. Though the strategy to respond to status outbreak is known and well defined, unfortunately none of these was present or could be actually put in place. These countries were just completely not prepared and they didn't have this ability. So this is just a chronology of the outbreak in Sierra Leone, I just quickly go through these slides because my time is almost gone. So you see it's like a wildfire. On 17th of August, eventually my team arrives to Sierra Leone, the first team, and the outbreak is still spreading. It is very much in the press and on the posters in the cities, and there are many problems like escape of people from the isolation woods, but also corpses lying around the cities. At the time where USA is deploying 300 troops to Liberia, America is accused about the terrorist experiment, you know, all these kind of perceptions and the conspiracy theory. So that is well documented in the local press, and eventually we arrived in the mid of August in Freetown, and we were deployed under WHO terms. These just pictures showing the kind of a preparation for this mission. And when we were in Nairobi, the Kenyan Airlines just announced that this is the last flight to Sierra Leone, so we already know that we're going to be stuck there. And in fact, during the first mission, we couldn't actually leave Sierra Leone. Eventually, after weeks and weeks, we were able to leave Sierra Leone on a private charter, which was organized by the government, taking also some miners back from Sierra Leone home. We spent some time looking for a suitable place to set up our lab. This is just arrival of the first and the second shipment. We're setting up the labs, and eventually this is kind of a design of diagnostic facilities which we set up there. We spent plenty of time to make sure that we've got backup power, because that's the problem, electricity and water. Eventually, on the 24th of August, we've got many delegations, both from the UN, WHO. Also, 25th of August, we are visited by the President of the Republic of Sierra Leone, and the same day I declared the facility to be fully operational. So the specimens are coming day and night, and we're very busy working 16 to 18 hours, sleeping, you know, very few hours, and I know that can't go like that for a long time, because, you know, I am risking my life, but also, you know, my team life. So, you know, that was just kind of the trend of the submissions. And, you know, this line just shows, you know, what was the capacity which we brought. And we know that this capacity is already exceeded. The problem was that, you know, some people were actually brought close to our lab. And, you know, this is just a sister of a brother. She just fell down on the motorcycle. They thought that we can actually treat them, but we couldn't. But while doing the diagnostic test, we saw this body lying for hours before it was collected. So that was also, you know, working on our psychology. Many of the specimens were actually provided in the wrong containers, like, for example, in syringes. This is a blood. Can you imagine that 1 ml of this blood contains millions of Ebola particles? So it was very, very dangerous to work with this. This is just handling of the bio-waste, and that's the teams of NICD which were planned to go to Sierra Leone. And training of NICD staff, that's the number of specimens we tested. The lab tested probably more than 11,000 specimens since it was established. But the most successful story was that when I realized that we actually very thin and NICD doesn't have the capacity, as a matter of fact, I asked the director to actually be helped by people from different sections, from different centers, and then we asked for volunteers. We had a staff meeting, more than 200 people, and I asked who would like to go. So there were 25 volunteers. They were given some time to discuss with families. Eventually 18 came back and they allowed to go. So we started to train people from different sections, but at the same time we started to train local people, local scientists. And eventually that culminated to the successful handover of this lab to the Sierra Leone Ministry of Health and Sanitation. The problem was that they didn't believe that their own people can do it. So I had to meet the president of Sierra Leone to convince him, and many, many ministerial officers, to convince them that we train your people to the same extent we are trained, and they will be safe. So this is the handover, and kind of a training, and we promised that we will help them, and we did until the lab eventually was decommissioned in August this year. Signing off, and these are NICD teams, all the people who actually working very hard there, providing the diagnostics for Ebola. And you can see some of these people are very happy. This is after 6-8 weeks going back, so they're happy to go back. Almost finished, okay. Some of the conclusions actually I discussed. I was asked to provide some information about the vaccines and clinical trials. There's at least 15 vaccines which were developed, but only 2 are actually in a kind of advanced stage of testing in humans, and they both recombinant vaccine. One is based on the vesicular stomatitis virus, and one is based on the chimp adenovirus, where the envelopes of glycoproteins were replaced with the Ebola envelope of glycoprotein. Different stages of clinical trials by different agencies, different countries. The same with drug. Unfortunately, there is not really a good drug for Ebola. The only license is vesicular stomatitis Ebola recombinant vaccines is now licensed, but it's not yet available for the public. Probably will be available for the public in about 1-2 years. And this is the last concluding slide. Sorry, Mr. Chair, I know I extended too much. Can you read on your own? Thank you very much.